Welcome to our State Trauma Advisory Board meeting. We're going to go ahead and call to order. Just a reminder, this meeting is being recorded. Everything said in the meeting or shared on the video or chat is part of the recording, which is posted to the Bureau's YouTube channel. Shelley, if we can do roll call, please. Alyssa Michael. Andrew Tang. Brent Burgett.
Present.
Brian Stephen. Charles Hu.
Present.
Clifford Jones. Damian Johnson.
Here.
David Notrika. Edgar Bissonette. Forrest Taylor.
Present.
Franco Castromarin.
Here.
Gail Bradley. Present. Garth Gamer.
Present.
Herman Butler. Iman Saizupan.
Here.
Nick L.
Present.
Nirv Patel. Zane Kelly, Dr. Kelly.
Here.
Dr. Southworth, Ryan Southworth.
I'm here.
Sandy Nygaard. Sean Bowker.
Present.
And Vicki Bennett.
Present.
13, I can't, 13, we have quorum. Excellent. All right. Thank you, everyone. Just a reminder, if you do need any Wi-Fi access for those in your room, Shelley has a little sheet with access. If you need that, that is available. For the chairman's report, the attendance report is in the packet. Just a reminder that if you missed 2 or more consecutive meetings, Shelley will reach out to you to see if you would like to remain on the committee. We would like to welcome a new member, Dr. Kelly. Thank you for joining the State Trauma Advisory Board. Welcome to the group.
Thank you.
We have 2 current vacancies that are posted. The first is a representative from a statewide rehabilitation facility. This position has been open for quite some time. If you know anyone that may qualify for that position, please let us know and let them know that they can apply. The next one is a new opening, which is a representative from an urban advanced life support based hospital that is not a trauma center. This is a new opening for anyone that is interested in applying. If you know a base hospital that is not a trauma center, that is open as well. If anyone is interested in applying, please email Shelley Bissell. Her information is on the agenda with her email address, and that will be forwarded to the governor's office, or I'm sorry, to the director's office for review and consideration. And if anyone is up for renewal, please make sure that you also submit your interest to remain on the committee to Shelley as well. All right, next for the Bureau reports. I think we're going to do a little bit of a shared presentation here.
All right, good morning, everyone. I'm Nicole DeQuiwit, the Assistant Director of Public Health Preparedness. If you haven't met me before, I'm the Bureau of BEMSTS Trauma Systems falls within the Division of Preparedness. I appreciate you allowing me to participate this morning, and just I'll start an update, and we are going to play a little bit of musical chairs, which might be different than what you're used to in the past. I just thought I'd give an update to start us off on some of our recruitment. So we know that we do have a number of vacancies continuing within the Bureau, most importantly, our Bureau Chief position. So that recruitment is ongoing, and certainly it is still open as well. So it will remain open until we fill with the right candidate. And we are very committed to making sure that we find the right fit for this role. We know how important it is. So if you do have anyone that's interested, please continue to share that recruitment announcement. We are moving through process, and we will interview folks as we go along, but we are committed to continuing recruitment as long as necessary to make sure we fill that with the right person. We do have a number of other positions, and Noreen could probably give an update. So we are recruiting for positions in the CON area, in our trauma section under Kim. We are recruiting for our enforcement section, so pretty much across the Bureau, but we are actively recruiting to fill all of those positions. As well, I just wanted to acknowledge that we are in a different space today, and thank you all for navigating your way over here. And we'll give more updates in the future, but ADHS, we are just going through a process to look at our space overall. and some of our business needs and how that might need to shift going forward. And so certainly we might continue to, you might continue to come to meetings in this space or potentially another, and then we'll settle on where our sort of regular and routine space that we'll use for these public meetings will be, but appreciate you accommodating as we shift around. We have construction going on, and again, also we are looking at space, and the Bureau itself may move within the building as well. So we're doing a little bit of shuffling, but we'll keep you updated. However, in the future, if that impacts any services, especially meetings. And I will turn it over to the next update.
The next slide, please. All right. So as we scroll through these slides, just a reminder that we do have the annual awards that are starting. So we have opened and those have gone out for nominations. So we have the 2 sets of awards. The first is the EMCT of the Year Awards for 2025. This will be the 3rd year with us giving these awards out. This has been really well received. The 4 regional councils have received information to go out to their regions. If you have not received information on how to nominate someone, that is something that you can go to your regional council directly. We also have a link in here, and these slides will be distributed after the meeting as well. If you want to nominate someone directly, this is the link to nominate them. We just ask that you consider their contribution to EMS, years of service, etc. The newer one, which this will be our 2nd year, is for the Trauma Award. So this will be for our 2025 Trauma Awards, and these will all be given out in May. We do have a really nice conference room reserved for our May meetings, as we've noted that we have quite big attendance with the award ceremonies, as the recipients like to bring their family to kind of be there for that recognition process. Again, things to consider: years of service, leadership, etc. Next slide. Just for this group especially, I want to make sure that you see kind of all the levels of what we have awards open for. So we have Trauma Program Manager of the Year, Trauma Medical Director of the Year, Trauma Registrar of the Year, Injury Prevention Achievement Award, Researcher Academic Achievement Award, and then Pediatric Champion. Last year, we did not have any nominations for Pediatric Champion, so that's my little prod. If you know someone that is actively engaged in pediatric trauma care, please make sure that they get nominated for this award. And this is the link as well. Like I said, this will go out to everyone. We want to make sure that this is available. Nominations are due March 7th. We will have a committee that will be kind of reviewing these. Bureau staff are not part of the committee since we are the regulatory oversight body for the trauma centers. So we have been getting some kind of people volunteering from different trauma-related committees. We are looking to see if there's anyone from this group that would like to help review any applications. So we're looking for 2 staff members. If you are going to nominate someone or are eligible for the awards, you should probably not volunteer yourself. However, if you're kind of, not actively in any of those positions, we would welcome anyone that would like to participate in reviewing that. It should be a quick, usually 1 meeting process to review any submitted nominees and select the candidates for that. So if you are interested, you can email Shelley or David Harden, and then we will add you to the list of individuals.
Or you can raise your hand right now.
Yes, or you can nominate yourself right now. So, but don't feel obligated to do that publicly. But if you are interested, it should not be a big time list. We want to make sure that we have good representation in terms of reviewing the applicant. And then the nominees will be chosen April 4th, and then May 8th will be the award ceremony with our staff meeting. Just a reminder, this year we are off our normal meeting cadence of the 3rd Thursdays of the month. We have tried to avoid big meeting conflicts, although we ended up with a big conflict today anyhow, with a large conference that was scheduled kind of after we chose these dates. But we are a little bit off calendar, so just make sure if you are kind of planning on those 3rd Thursdays of the month, that's not the meeting cadence for this year. Next slide. EMS portal changes. I don't know, Leah, I think I saw you online if you wanted to cover this.
Yeah, so some changes that have been going on the LMS side, on the licensing management side. The main one is if you're on the licensing management side, make sure your rosters are up to date. That way, when we sync the agency, we sync all the correct information from the LMS side to AC peers. The second change that we're working on, there were some changes like on the tech world. And now the emails have to come direct. Before, we had no reply at ADHS.com. the email have to come now directly from email trend. So instead of seeing the non-reply at acdhs.gov, you're going to see emails come from acdhs at arizona.imagelicense.com. Make sure you bookmark that email, or if you have to let IT know, let them know, because they'll be making that change this month. So make sure you bookmark those emails. And then the last update that I have, you might be seeing, but we're making changes to the pages overall to include the new ADHS website, or the state website, and all the color schemes that come with it. Make sure to keep an eye out on those. If you have any questions, just email us, or we're regional coordinator. Thank you.
Thank you, Lucia. And yes, just a reminder, if you are looking at the agenda, the new logo at the top is the new color scheme. So if you receive emails or communication from the Bureau department, that it is not spam, this is the new logo that is being utilized. So we've been trying to get that out in as many different formats. The email address, many people have been used to a .gov. They feel pretty comfortable opening .gov emails. So really just make sure your personnel recognize that the EMCT recertification will be from a .com email address, just for awareness purposes. Next slide. All right, I think we're going to hand it over to David for an update regarding the Governor's Office of Highway Safety Grant. And the agenda also, the slide deck will have a link to the updated Bureau statutes and rule book. This is posted to our website, but this will go out as well. This will be a live link if you wanted to have the updated one.
Yes. Yeah, the Governor's Office of Highway Safety, they have funding they get through DIPSA, and it's an annual appropriation that deals with highway safety and traffic safety. As you're probably aware, the Governor's Office of Highway Safety has several grant categories for law enforcement, fire, EMS, and others. This is our second year with our grant. It's designed primarily to cover the cost for the EMS, the trauma registries. That can be quite expensive, so that helps a lot with the state budget for the Bureau. There are other programs too that's got rural fire departments that apply to get extrication equipment. Feel free. But okay, yeah, I missed that one, didn't I? Also, the statutory rule book has been updated. It's on the Bureau's website under regulatory references. That's been updated, reflecting last year's changes to DIRC and statutory changes in the legislature. Other than that, if you're interested in more about the Governor's Office of Highway Safety grant application, send me an email and I will put you in touch with the link. Grants are due March 7th of this year, so feel free to let me know if you're interested in applying for funding. Thank you.
Thanks, David. Next is a brief update. I know we had mentioned that this was coming, but it is officially live. We want to make sure that everyone is aware. So scope of practice has been updated to include the new EMR as well as critical care endorsement for paramedics. So those are live and have been updated on the Bureau's website. If you go to the main Bureau webpage in the bullhorn section in the kind of top center of the page, you will see a link to that as well. So those are live and active. Next slide. And the drug tables accompany that as well. So there are significant updates to the drug tables. Predominantly, we've updated the table 3B, which is the hospital-based one, to really clarify what would be a general paramedic versus a paramedic with a critical care endorsement. So if you are a hospital and utilize paramedics in your hospital facility to provide care, please make sure that you review those drug tables, as there are significant changes to that. We have tried to align the more critical care related medications with paramedics with a critical care endorsement in that setting. Table 1 has been updated also just to add EMR column as well as critical care endorsement too. Next slide. All right. Next is about seal and compliance. I'll hand that over to, I don't know, Mike or Noreen, which one are you handling this one? Mike?
Surprised. So what exactly are we talking about? The
These are just some of the updates. So just a reminder.
okay, Noreen, I'm not.
Okay, so with as far as the ambulance and you know that says that the ambulances are inspected every 12 months. That's not new. There is this is an old slide, I think, from our last meeting, but there is a ambulance checklist updated on our website that reflects the new rule changes. Also, too, those folks that had to submit a GPS waiver, which is a requirement now for ambulances. They have to renew those waivers now because they have to be annually updated. I don't really think that, like I said, this is an older slide, so we've been on there. So that's really all I have.
Okay, thank you. Next slide.
Actually,
Oh,
a question regarding this. So the GPS monitoring devices, and applying for waivers, do we know how many applied for a waiver of agencies?
We do, but I can't tell you off the top of my head, you know.
And then is that a continuous waiver that they can apply
Yep,
for? on an
annually.
annual
If-
basis? So they may never actually have to install that.
That's the way the statutes and rules are written right now.
Thank you.
We have a hand raised.
Dr. Gamer?
Yes, Noreen and Gail, could you refresh my memory? What does the definition of immediately entail? CONs must report criminal convictions or statute rule violations immediately. Is that same business day?
In regards, this is a CON related slide. So are you asking in regards to this, Dr. Gamer?
Well, I presume that's CON holding agencies. And the representative of the CON holding agency, when would their requirement be? Immediately, as in same day?
So, Dr. Kramer, Nicole, we would advise CON agencies to defer to your own legal counsel around that definition, but immediately, there's no specific like 1 day, et cetera. Immediately would mean as soon as you are aware. I don't know if Dr. Bradley has
That's good.
anything to add, but
Understood. Thank you.
Next slide.
I can take that. Hi, everybody, this is Adam. So the naloxone leave behind program continued to expand. We had 47 partner agencies. Over 3,500 EMCTs have been trained in the program specific training. It's not like the naloxone administration, naloxone harm reduction type of training. And that represents better than 15% of all EPs in the state, which is a number that we're just really ecstatic about. And we are approaching 5,000 kits shipped. That kit sent out to agencies, and the better part of 10% of those, 558 kits have actually been left behind on scene with at-risk parties. And so we hope to continue to expand that program. It's free. It's very low barrier. We just need a letter from your medical director saying that they agree with it. We'll get in touch with you and get some of your folks trained up and get you some kits in your hand. So that'll be it's very easy for you to participate if you want to. Contact myself or Dave Hanson if you would like more information about naloxone leave behind. Thanks.
Thank you. And I just want to really highlight this. I think when we first started this program, I don't think any of us expected that we would have 47 agencies actively enrolled already. We're getting just kind of the more agencies that we speak, that see other people doing this. This is really remarkable. We also do know that while 558 kits is over 10% of the ones that have been sent out to agencies, we know that many agencies have had crews that have accidentally given the kit out, forgotten to scan it. And that's okay. We like to get it scanned as much as possible, but the goal is to get the naloxone out into the community to at-risk individuals. So we do know that the number of kits actually handed out to individuals is much higher than that 558. So just really a big thank you to all the agencies that have participated in this program. We really feel like this is a huge benefit for the citizens of Arizona.
Yeah, thanks for that, Dr. Bradley. The QR code that's on each individual kit is the same QR code across all of them. And so if you lose the one you're handing out, just scan any one of them, and it collects the same data. Thank you.
Hi.
The EMS for Children program has launched what they're calling the MARC program, the Making Arizona Ready for Kids program, and this is the first of its kind recognition program for pediatric excellence in the fire and EMS agency. We're the counterpart to the AAP's hospital recognition program, pediatric excellence. The way the program is designed is there's a window for application. So we're currently promoting that. And that window is open until February 14th. With the program comes support and resources for increasing pediatric readiness. If you're interested in that program, contact myself or Aubriana Smith. We'll see you there. And finally, share is we are continuing to work just to maintain our hospital renewals, referral and recognition, referral and receiving centers. Sorry. We're also working to prepare a shared database for annual report production. And that is a task that many hands involved, especially with our data and quality assurance team working very hard on that. Patch share resources and patch share reports and other resources can be found on our website. And for any other questions about share related things, you can follow up with me. And then I have a counterpart in the data and quality assurance area, Josephine Johnson. Like any further questions about share? Thank you.
Thank you. And then just a reminder for those EMS agencies that are Premier EMS Agency Program as part of our improvement of our data quality for the SHARE program, effective January 1st. We are now have, as approved by EMS Council, the SHARE or cardiac arrest data element that to maintain PEEP status, agencies will need to maintain a validation score on these additional elements. So this is something that we think will be a huge benefit to our data entry. Previously, when the SHARE program was first designed, many agencies were still on paper charts, and there was personnel that were actually reading narratives to get this information. As we are here 18 years later, we recognize that it's time to evolve a little bit more and utilize the technology that's out there. And this is all built in your ePCR platform. So if you have a NEMSIS 3.5 compliant platform, then you will be able to do all these data elements. So just a reminder, we are continuing to get this information out, and we'll make sure that everyone is up to date on that. And just last slide, we really want to plug some of the work that's been done by our GIS team regarding maps. There are links that will go out in the slide deck as well. There's quite a bit of information in here if you're looking for any information regarding trauma centers, cardiac centers, base hospitals, et cetera. All of that is available in the GIS portion of our website. And just another plug for our dashboard, Roxanne and her team do an incredible amount of work. As you see, when we have our state trauma report that gets updated on an annual basis, and this is really quite remarkable, the amount of data we do have available. We know that some parts of the state are actually utilizing this information to apply for grants and have gotten funding for programs based on this. So I really wanted to just keep plugging this information as a huge benefit to the state. Carissa, I will go ahead and hand over to you for the trauma registry update.
Good morning, everyone. So for those of you who may have missed the announcement we sent out last week, the RFP was closed last year and now it's concluded, and we are happy to announce that the award was granted to ESO. So we have been working with them migrating over to their new registry as of January 1st. So the hospitals that are not web-based, they're not part of that group, but those of you who are web-based have been moved over to the new registry, and ESO's had a great implementation team that we've been meeting every week and working out some of the bugs and getting moved over. So that is good news. So just a clarification too. So all 2024 records are still going to be closed out in Trauma 1, and then 2025 records are going to be going into the new registry for those web-based facilities. Those of you who are non-web-based can continue entering in your 2025 records in the desktop version of Trauma 1. So the next big part of it will be moving over our old Trauma 1 legacy data, but we're not going to be starting that until July of this year. The reason for that is the registrars are still working on data in Trauma 1, so we don't want to start moving that data over until it's completed. So any questions on this slide so far? Okay, so I've gotten a lot of questions from registrars and trauma program managers about the financial data upload and the ICD-10 generated ISS scores. So those are part of the RFP requirements, and so those are some things that aren't in place yet with the new registry. So we'll be working closely with ESO and their team to address those topics as we move forward. So I did want to let you guys know that. I wanted to let you know that we're still doing the Q&A meetings every Tuesday. The full data set is 1 to 2, and then Wednesday is a reduced data set from 1 to 2. And that's just a time for the registrars to ask questions and that kind of thing. But you can attend both. We just divided it up so that each of the different groups would have their own time, but a lot of people attend both, which is fine. And then also the registrars, if they have specific questions or they're seeing kind of some kind of weird validation flags that they're needing help with, they can email traumatraining@eso.com to submit a support ticket. They can schedule a time for some one-on-one help with ESO, or you can always reach out to me and I can do my best to help as well. So those are the updates for the registry, and we'll just keep moving forward with any new product. It's a learning curve, and there's going to be a lot of muscle memory, right? Learning a new system. So we're in that phase right now. So does anyone have any questions for me? Okay, great. Thank you all.
I was expecting lots of questions because we've had lots of questions in some previous meetings, but at least we have a decision on that now moving forward. Just for attendance purposes, I do see 2 of our members did join the meeting. Dr. Tang, if you can just come off mic quickly to confirm attendance. You can also type it in the chat if your mic is not working.
It's I'm here.
All right, thank you. And then Dr. Jones. Okay. All right, thank you. Just want to make sure we captured your attendance for the meeting today.
Can I just make one comment?
Yes, go
Just
ahead.
before we leave the trauma registry piece, I just want to make one comment to just say thank you to everyone who, for their patience through this process. We know our RFP process was lengthy, to say the least. So just really appreciate the cooperation, and definitely want to thank Rita and Kim in particular for working with all centers through the transition. I think we're just really happy that, and I'm sure you all are, that we don't have to make yet another transition. But again, just want to really thank everyone for their cooperation and their patience, and for working with our team to get us to this point. So anyway, I didn't want to let that item go without saying that. And I know it's been a interesting couple of months, but we're definitely, and years if you've been following our RFP process. So we're glad it's closed, and just want to thank you all.
Thank you. All right, as we finish up the Bureau report, just a reminder, if you are interested in being on the panel to review the trauma award, please let us know and we will make sure that we add you to that committee. Moving on to our standing committee report. Sean, do you have a TEPI report?
I do, thank you. TEPI met on November 21st. And the minutes were approved as presented. Adam shared info on TEPI Share user group meeting that was held on November 6th. Julia shared information on pedestrian data opportunities and outcome of Arizona Department of Transportation, Governor Office of Highway Safety Grant Workshop. For more information, contact Adriana Smith at azdhs.gov. The group discussed pros and cons of displaying the number of agencies that report to AZ peers. And this wasn't a voting item, but a consensus was agreed to, and we all agreed to an annual number to post on the snapshot area of the dashboard. The ADHS heat-related surveillance dashboard was displayed and briefly discussed. We also talked about pediatric drowning data, and then Adam shared areas of application streamlining on the Heart Safe program requirements to try and make it easier for entities to apply. And that's it for the TEPI report.
Thank you, Sean. Next, I think Shelley is giving both the education and PMD reports on behalf of a couple of our members.
For Education Committee, they approved their minutes as presented. Dan Majeski shared information on the psychomotor exam moving forward. They approved their updated Safe Fleet training and toolkit, which is now posted. They approved the TXA training, which is also posted. Julie and Rachel shared slides showing the outcome of the paramedic educational grant to the region. And a Gov Delivery bulletin that announced the scope drug table certification and training rules was revisited. They voted to approve forming a joint work group with PACES to make a training for EMS providers for children and youth with special health care needs. They did meet on January 16th, and they will have a second meeting to be announced. And we received some requests for the March meeting. I think that's it for education.
And just to plug quickly, for this committee related to TXA, that is something that we had stakeholders had requested to have some TXA education put together. So a big thank you to our education committee who has produced that education curriculum that is available on our website. If your agency would like that for trauma programs, if you want to do outreach with any of your EMS agencies as well, we do have the education curriculum available.
All right, moving on, protocol, medications and devices committee. They approved their minutes as presented. Gail shared the process for updates to the drug table. Moving forward, I have a sheet I keep track of requests that we receive. And then we work through them on a rolling fashion with PMD approvals and then the final annual MDC approval. We revisited the big changes to scope, drug tables, and certification and training rules that kicked off January 1. And then Anne provided some medication reports for emergency and interfacility usage. So we looked at those. And that's it for P&D.
Thank you. Heather, are you online for a trauma program manager workshop update? Okay.
So the Arizona Trauma Program Manager workshop has not met since the last meeting, but our next meeting will be tomorrow. Crystal will be available to answer any of those burning RFP questions for ESO. And we also have some host speakers, and the afternoon session will be dedicated to an in-person stop-and-bleed train-the-trainer class that PCH and Dignity have graciously offered to host. So far, we have almost 60 people signed up for in-person attendance, so we're really excited and hope to see everyone there. It is going to be held at Banner Desert Medical Center in Mesa tomorrow morning.
Thank you very much. All right.
Sure.
Oh, go ahead. Thank you.
Okay, hi, everybody, this is Adam again. Picnic met on November 21st. The minutes were approved as presented. Vauxhall and the DQA team shared the qualitative ATV data and program. Morgan Anderson shared some information from the Arizona Child Fatality Review Report. Dr. Gator presented a toolkit that they worked on that is now posted on our website. Tech role description guides were approved. We needed some description on our tech is our pediatric emergency care coordinator, a volunteer position at any hospital or EMS agency that just tried to improve pediatric readiness with that agency. So those role description guides were created and approved at that meeting. We approved a joint work group between the EDU and for the education and training for children and youth with special healthcare needs. We've conducted the first of those meetings, and we had a follow-on meeting to come. Ariana reported the updated safe sleep and training toolkit were approved at the education committee. There was a motion approved to form a work group to revisit the bylaws for PIG. And finally, I call to the public, Mr. Chris McCarthy, who represents RAPM, the Western Regional Alliance for Pediatric Emergency Management, spoke about a pediatric pandemic network project that focuses on hospital disaster response in healthcare facilities for pediatrics and healthcare facilities. And that's all I have. Thank you.
Thank you. All right, moving on to discussion and action items. If I can get a motion to discuss and approve the meeting minutes from September 19th.
Motion.
Thank you. Can I get a second?
I didn't hear.
Second.
Dr. Fleischmann.
Thank you.
And online, if you can say your name with the second, please.
Southworth.
Thank you, Dr. Southworth. All right, any recommended amendments? Any opposed? Any abstentions? All those in favor say aye.
Aye.
Members, if you can please make sure you come off mute to say aye or put your vote in the chat as well, please, so we can capture those.
Aye.
Thank
Aye.
you.
Aye.
All right, next there's a standing
Aye.
item for catching up, actually. All right, we have our standing item from the American College of Surgeons Committee on Trauma report. Dr. Patel is out of the country, so he's not able to be here in person, but he did provide us a report. And I know, Vicki, you were going to cover part of this as well. From his report, he said that they have their annual meeting coming up in March of this year. Part of that discussion is going to be some of the changes that they are seeing across the country in regards to verification timeframes with the new book. So he definitely wanted to, I know Kim's going to cover that a little bit, but he would like feedback from the committee to take forward to ACS when he meets in March. Education-wise, he said that ATLS Global Symposium is going to be meeting March 14th through 16th. And then they're looking to update the ATLS 11 edition. There's Team 4th edition is now available. RTTDC is undergoing the revision, and Bleed revised course is currently available as well. And then TQIP is scheduled for November 10th of this year in Chicago, Illinois. Vicki, did you want to cover the information about verification?
Sure, thank you. Not a lot to update from our last reviewer meeting. I can share with you that site visits so far through August of 24 were tallied, and there were over, I think, 235 surveys, with the majority, obviously, re-verifications at over 85%. I think some of the concern has been, are these standards harder to judge? Are they harder to pass? And I would say that the standards sometimes are a little bit more vague right now for some to interpret, and they're trying to continue navigating that with providing guidance and documentation, factors in the facts, as well as accepting your feedback online. So I encourage everyone that has an ACS visit or has any questions, certainly go to that online link and put your information in there, because they do retrieve that weekly, and they have meetings to go over those to try to make this easier for us. One of the other things that has always been a concern that I've heard voiced, and I think we've even talked about it at this meeting, is the consistency with review teams and with the actual reviews. And one of the things that has been put into place for this very reason is to have a post-review committee team that actually reviews the report and aligns that with the surveyor findings as well as with the actual standards, to look for any opportunities of anything that could have been missed or anything that was erroneously cited. So I think they are trying to hear and listen to what we're saying. I do think they're trying to make the process fair, and they will continue to try to revise and update the standards in future. I do not have anything for when a new edition will be coming out, other than there are some comments and things that they are looking at, in particular related to the PI chapter, the registry section, and also subspecialty coverage. That's pretty much it for an overview.
Thank you, Vicki. Next, we're going to turn it over to Kim, who's got just a little discussion and some slides to share regarding some ACS verification trends.
Okay. So I've been asked to kind of give a little bit of some feedback on how our state trauma center verification trends have been going. I'm happy to see that a lot of things that you're going to be hearing in this short presentation is aligned with what Vicki just shared. I think you'll find there are some things that I think for the folks that are not familiar with the VRC and ACS's process. But I do just want to start off by saying that the department and we are not subject matter experts on ACS's standards, and I'm not here to speak to their standards. That's, you know, what Vicki and Dr. Patel are kind of here for. This is just some information that I quickly gathered from my notes and from the EMS portal, and some resources that I also got from the Resources of Optimal Care of the Injured Patient, the 2022, which is now what everyone is referring to as kind of the gray book. And so certainly if you need more clarification on the ACS side of things, please visit their website to get that information. One thing that I have seen causing a little bit of confusion, and like I said, for those of us who are not well versed in the ACS speak, there are two types of verification standard deficiencies. They have type 1 and type 2 standards that you can have. I think they call them instances of non-compliance or non-compliant standards. The type 1 standards are considered critical standards that directly impact patient care. And then those type 2s are just kind of everything else, whether it's more of an administration report chain, whether it's your policy or job description, and those kinds of things. Another good thing to focus on or look at when you're in your exit interview is how they break down those standards and what it means for your verification cycle. So if you're compliant with all of those standards, you will be verified with a 3-year certificate. If you're not compliant with up to 3 of those type 2s, then you can be verified up to 1 year with a corrective action plan or some sort of follow-up. It could be a focus visit, it could be done paperwork-wise, and all of that's just going to be really based on what standard is non-compliant, and that's something that ACS will work out with you. Now, the non-compliant, if you're not compliant with any type 1, and remember we said that those type 1s directly affect patient care, or you're not compliant with more than 3 type 2 standards, you will not be verified. More than likely, that's their standard. Now, the caveat to that you can see down below is that all the final decisions regarding compliance with the standards will be made by the BRC committee, and they could differ from the findings stated at the exit interview. And that kind of piggybacks off of what Vicki was saying as far as they have to see a committee that's doing the post kind of hot wash on how the review went and making sure that it's being across the board implemented the way that they want their standards to be assessed. So, and also the VRC can take into other mitigating circumstances and make other decisions that's in their purview. But certainly if you are in a ACS visit for your facility and you receive a type 1 or you receive more than 3 type 2 standards, I think it would be a very good idea to reach out to myself to figure out if there is any sort of recourse or plan B that could be in place as far as pursuing your designation based off of the state standard. And so when I wanted to take a look into what we're kind of seeing as our trends, over the past 12 months, we've had 12 separate verification visits. One of those visits was a focus visit that was kind of cleaning up on an already identified non-compliant standard. One just actually happened last week, and we don't really have any information on that. And we have 2 centers that came through unscathed with no deficiencies whatsoever. And then you'll see the majority left had focus visits and or did not meet the verification standards of having more than those 3 type 2 deficiencies. And when we take a deeper look at like what we're actually seeing in those, there were 21 total deficiencies across those 8 facilities that received the focus visits or not being verified. All of those were type 2 deficiencies, and I kind of broke it down into some of the top areas that we're seeing. And again, it's good to see that we are aligned with what Vicki has reported from the ACS. She has cited that a lot of things that they're seeing are the registering and PI staffing. You can see here that a good portion of that was the patient record completion. ACS has some new requirements as far as reducing the number of charts for your FTEs and having a CAISS specialist. And then, of course, we have now standards for performance improvement staffing. The next one behind that we're seeing is the screening and intervention. So we had a facility with mental health screening, which I believe is the new Grade Book standard, and then the alcohol misuse intervention. So it appears that the screening is being done, but they're missing on some of the intervention standards. And then the third thing, which also Vicki mentioned, was the response times for the subspecialties. So we have the neurosurgical response and orthopedic surgical response. And there has been a lot of discussion, I think informally, like I said, I'm not speaking for the ADF, but there's some informal discussion saying that, it just may be that it's not being done, or is it just not being documented in a way that provides evidentiary support that you're meeting the standard? And so I think that will bear itself out in time. And then the other kind of handful of things I put on there was some transfer protocols, reporting structure, disaster management, and we had one documented effectiveness of PI. And so those are kind of just a quick overview of what we've been seeing, what I've been seeing over the past 12 months specific to our Arizona facility. Is there any other questions that you guys have?
Can you maybe go back to the bar graph one?
Sure.
So I just wanted to focus this. I'd asked him to put this together. So thank you for this really great summary. I think this is a huge change from what we've seen historically from ACS in Arizona. We've typically seen, especially our level 1 facilities, routinely getting their 3-year verification. So when we see 8 out of the 12 getting a 1-year verification, that is a significant change from ACS. This is not just specific to Arizona, and speaking to other state EMS medical directors, they have seen this trend in other states as well. I did talk to Dr. Patel about this yesterday, and he would really like feedback from the trauma facilities as well as this committee, if there's any feedback that he can take back to the ATS when they meet in March regarding any challenges potentially associated with the new gray book. So, that can be shared in this committee or in an email as well. Yes.
Yeah, I think the challenge is the 30-minute response time. That is at the bedside. That is from call to bedside. And what ACS doesn't realize, the call comes in as the muffin is being baked, meaning they're in the CT scanner. We don't even have a read yet. They see blood and they scream, blood, 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 come in. Well, now the time is clocked. It's going. I have to wait till the time is even available. So right there, 10 minutes goes and ACS thinks America is only made out of little villages where we can have a 10-minute ride to get there. So I think that is a big problem that they actually measuring the 30-minute clock.
Thank you.
Hey, this is Andy from Tucson.
For neurosurgery that is not bedside, for neurosurgery that's phone call accepting that they have accepted the consult, 30 minutes to bedside is required for the orthopedic surgery.
Neurosurgery has certain criteria for 30 minutes. That's new.
Correct, but it's not the bedside.
It's written in the textbooks, and we're doing it as a bedside. But we'll check again.
Yep, review the great book.
Yeah, this is Andy King from Tucson. I was going to make the same comment. For neurosurgery, decisions can be made based on imaging. Vicky, you can verify that, but that's my understanding from the grade book. Orthopedic is different, right? The neurosurgery, I'm pretty sure it falls into a little more relaxed.
Yeah, I actually have my hand up to comment on that. You're absolutely right, Dr. Tang. The ACS, BRC committee, COT all agreed after consideration before the standards came out that neurosurgery can look at films and develop a plan of care in that response time. And that's what they're looking for now, is a response to a plan of care. So that if your patient is in CT, you pull up the film, they have a terminal head injury, your plan of care is comfort measures, there is no operative intervention. That all can be done after you review the films and document that. The key piece is documentation. So obviously orthopedics is still required to come to the bedside. It does say to the bedside. If you read the neurosurgery piece, it talks about an evaluation. So I think that's an important distinction to make so that you can assess what works best in your facility. They're certainly not going to tell you not to respond, but they wanted to give you that leadway. So there was some judgment that could alleviate those response times that were not necessary. The other thing I wanted to tag on to what is mentioned here about these focus visits is, if you'll notice in the standards, there were a lot of registry related standards that if you miss one or two of those, you could get 2 type 2s, you could get 3 type 2s. And so what they're looking at now is, well, why do we have all these standards for the registry, but yet our PI standard is, if you remember back to chapter 16 in the ART book, there were multiple areas in the PI chapter that could have been cited, whether that was identification of elements, whether it was loop closure, whether it was documentation. All of those things were counted separately. So they combined them in PI, but yet they separated them out in the registry. So that's another thing they're looking at, is what really needs to be combined and what needs to be called out, because we've seen this uneven balance here. And so that is another thing they're looking at. I think the other important thing when we say focus visit, that is not an in-person focus visit. The majority of things that you see here on the screen will be a paper submission, where the focus visit, where they actually do another virtual visit, look at cases, is related more to your PI process and any issues with patient care, any response times that may have impacted patient care. But like your registry, your mental health screening, your intervention, all those things will come with a guideline and a monitoring for % of compliance that can be submitted. And that will, if accepted, will extend your additional 2 years without a complete virtual visit. So I just want to make sure everyone understands that it does look like it's more. There's several factors weighing into that. And they're certainly looking at how to best address that. So I don't know that we can compare before and after, because we have apples and oranges. We have different standards. They're broken down differently. If you look at the total globalness of it, yes. But if you break it down to the reasons why, then I think it's hard to do that comparison. Thank you.
And I would just like to leave with one last thought. And unfortunately, most of you will have, most of the APS verified facilities that we have already went through on the gray book or have a majority. But I would say that the state in 2018, when we rewrote the trauma rules, we really worked hard to put in a state pathway to help support verified centers. So in 2018, we do have a standalone pathway for level 3 centers. And then we also have a pathway for level 1 centers, should they not be issued verification at the level of designation that they're seeking. So I say all of that to encourage centers, if you feel as though you may have more than the 3 or even 2 of your type 2s that you're on the fence and are really not sure if you're going to hit that standard of less than 3 type 2s, that you communicate that with me, and we can really guide you on what application to fill out, and we can assist you through that process, and if needs be, work with you with the corrective action plan should you not gain that verification at the end of your visit. So that's always an option.
Yeah, thank you, Kim. I think that was really one of the takeaways. Kim is very familiar with the ACS verbiage, and so sometimes she has sat in some of these exit interviews and realized that the facility is not likely to get renewed, and the facility does not recognize the language that they're being told in that exit interview. So that's why we want to make sure it's very clear what the potential outcomes are based on the exit interview. And if there is that possibility, start early. I think ATS usually takes a couple months to get that final result to the facility. That would be enough time to start the process of communicating with the Bureau and with Kim to figure out other options for your facility. So we really want to help facilities, support them, work on those corrective action plans that can maintain services across the state. So thank you very much for providing that information. If anyone else has any feedback regarding the new gray book criteria, verification pathway that they would like to share with Dr. Patel, you can send that directly to Shelley, Kim, or myself, and we will make sure that that gets to him so he can take that to the national meeting in March. Are there any agenda items to be considered for the next meeting? Hearing none, call to the public. T. Todd Nichols has his hand up.
Hi, can you hear me okay?
Yes, we can.
I wanted to very briefly, considering we're short on time, I wanted to very briefly share an initiative that is being led from the Arizona Trauma Association, and we would appreciate this board's participation if appropriate. I'm going to share my screen really quick. Are you able to see that?
It's coming up right now. Give it 1 second. We can see it now. Thank you.
Okay, great. So this is an effort, again, by the Arizona Trauma Association, led by myself, Dr. Iskander from Valleywise, and Patty, who is a Banner employee, but also the, I think, executive director for ATA. The idea for this project came out of a couple things, a case that we saw particularly at Phoenix Children's, where there was many opportunities for improvement and communication, and also after a level 4 site visit where this issue in a larger scope was brought to light, and we decided to start doing something to tackle it. Kind of what's in it for us, what we hope to accomplish out of this is to improve patient outcomes, particularly for patients that are crossing the border that receive care in the United States but are Mexican nationals and vice versa. We think that there are patients that could be better managed by better collaboration across the border. We want to coordinate those partnerships and relationships, and hopefully that will facilitate better discharge planning, return to home, follow-up care, and all of those things. And then finally, we want to just make sure we've got open lines of communication. We've got contacts and individuals that we can reach out to in Mexico and be available to them so that we can communicate about issues or opportunities. We've sort of started to establish what a minimum viable product for this effort would be. It's kind of broken into 2 sections. One is communication and coordination. And the goal here is to establish some lines of communication and coordination. We consider a comprehensive contact list, maybe maps included for locations of centers. And that would include any hospitals, clinics, EMS agencies, and trauma organizations if they exist in northern Mexico. Major Mexican trauma health systems that are the tertiary referrals for that area, any government organizations related to this. There is an Arizona-Mexico Commission that's been around for, I think, more than 60 years that has a health services committee, and we're going to see if we can partner with them because I think there's a lot of overlap in what their efforts are. And they've got a few events coming up that we're going to potentially participate in, and we'd also like to see if they've got any funding mechanisms for this. Also related to this goal is developing an advisory council to participate in kind of overseeing this initiative, drafting a charter, identifying memberships. And then as far as collaboration, we want to try to optimize patient care across the border. We want it to be bidirectional, and we want to share guidelines, clinical practice guidelines, that kind of thing, feedback, maybe do visitations, simulations, education, and so on, just to help bridge that gap. A number of key stakeholders we've identified include members of the Arizona Trauma Association, the Bureau, the border liaison, Michelle, and then, like I said, it would be ideal if we could have either a representative from STAB or some kind of engagement from STAB. We've engaged already the University of Arizona's Rural Health Program. We've got a few level 4 and 3 and 4 critical access hospitals in southern Arizona. We are going to be connecting with the Border Patrol, some EMS programs, and then finally Robert Guerrero. He's the former border health officer, but he works now in Senator Kelly's office, and he's got a wealth of knowledge and background on this. So our action items, again, some meetings potentially with the Health Services Committee of the Commission, this presentation and meeting here, and we're going to work on getting, try to get a meeting at the governor's office with maybe highway safety or whoever's appropriate. We're going to look into some funding mechanisms through the commission, through University of Arizona, maybe through the governor's office or for grants. Form this advisory council by developing the membership list and the charter, and investigating research opportunities along these lines using state registry data and looking at quality metrics on both sides. And for anybody that's interested in more information or connecting offline, my email is here. And with that, I would be happy to take any questions or comments.
So just to confirm, Todd, what is your ask for this committee?
We would like the STAB to be in the loop on our efforts. So we could either, if based on your request, we could have reports regularly on the progress. It also would love to have a member of the board participate in our advisory council.
I will check with Shelley on what is allowed. I don't know that a member of the board directly representing the staff can serve in that committee, but I think certainly any members of the committee could serve in their outside role. I just think of the way that open meeting laws work with that. I don't know that a direct committee member can represent staff on that committee. However, certainly any members of the committee that are in the trauma community could participate.
We could add it to like a report. That's the,
Yeah.
the action item.
Yes, we can certainly take a report update, but I don't think we can have a member directly representing staff on that committee.
Okay. To that point, I guess then if any individuals are interested in joining this effort, please do email me.
Thank you very much.
Will you be sharing these slides too?
Todd, is it okay if I share your slides out with the?
Yeah, I'll send you. I made a couple changes, including my email. I'll send you the updated version. You're welcome to share it.
Okay, great. Thank you.
All right. Thank you.
Thank you. Upcoming events are listed on the agenda, so feel free to review those. Our next meeting, again, reminder, this is different meeting cadence, will be May 8th at 9 a.m. And there is a hyperlink to our 2025 schedule as well. If I can get a motion to adjourn.
Motion.
Thank you. All right. Meeting is adjourned. Thank you very much, everyone.
Thanks, Al.
Thanks, everyone.